important topics in exam, how to differentiate between benign and malignant compression fracture. It is in every exam you will see this type of question, either MCQ or if in the short question or long questions. And you should be carefully know the differences. As you know, the malignancy like the posterior part of the spine, so it's like the more the pedicles. You should look in the other levels of involvement and check if there is any abnormal segment, because the malignant always like this pattern. Always when you check the cortical destruction, because the cortical destruction is like a clear feature of malignancy. So you should be careful about it. And always you have similar to this type of comparison between either degenerative or osteoporotic fracture or metastatic fracture. To be honest, it's any exam I entered or anyone who entered exam, I think he will clearly see that this type of question. Always the fracture who is osteoporotic or degenerative is the compression fracture always parallel to the end plates. The most important here, to be honest, the bulging cortex and the soft tissue component. If you see the bulging cortex, this posterior bulging or soft tissue component, you should think about the malignancy. You see here like many things, especially the in out of phase sequence is very useful. Also about the other vertebrae is going with metastasis. If you see multi-level, this is going more with metastasis. We mentioned before that the sponge or the compression fracture, and especially if you have this fluid signal in T2, and there was one question about this in the FRCR that they asked, if you see the T2 fluid signal in the old fracture, this is characteristic of the osteoporotic fracture. Okay, so let's apply. If there is any volunteer, you can tell us in this image who is favorable. Is it malignant or degenerative? If you just write, or anyone can mute himself and just let me know if we are chatting. So be more we are together, we are not in a challenge, so don't worry. Any answer, it will be malignant. Why malignant? As we mentioned, this is the posterior cortical bulging. Yes, exactly, Dr. Marwa and Dr. Ala. So the bulging in general, this going with malignancy. Also the soft tissue component. So from another example, this which type of fracture you are going with, is it malignant or osteoporotic? I think clearly, exactly, it will go with benign, because you see the T2 high signal or the fluid signal in the stair or T2 based sequence. So whatever you see this sign, you are going with benign fracture. Another example, I think you start now exactly, Dr. Marwa, and parallel to the end plate. So we are going with benign compression fracture, whatever you call it, benign or degenerative, because there is much causes for this. But again, if you see this fracture, which type you are preferring? Also the vacuum, exactly, Dr. Ala, the vacuum phenomena is going to be pathognomonic for degenerative fracture, exactly. There is what it could be, because this is characteristic of benign fracture. If you see it one time, you will remember it always. So what is could be? Any volunteer, someone like to chat or to draw? I see someone is trying to draw. Okay. So what is could be? No, it is not Gebas, not Jebas deformity. It is called, exactly, Dr. Amaro, it is retrobulging. So when you saw or you see this retrobulging, you are going with degenerative or compression degenerative fracture. Is not malignancy. So again and again, you will see in any textbook about this comparison is very, very important. So please, carefully, you should check it. Something very characteristic, that the cortex is always, the subcortical is with the benign, the cortical is with malignancy. The mass or enhancement, as we mentioned, and the retrobulging with benign, as we mentioned. So, and the vacuum phenomena again. So just carefully try to figure it. The spine have many issues. When you make it, you should make post contrast. So in the image of post contrast, what you can see in this case, can you see something like epidural enhancement here? If you saw this, and you can see this, something here is going. So what could be the differential? This very important differential. So this also one of the most important things that can come in the exam, the differential of enhancing coda equina, thickened enhancing coda equina. Sure, it will be including the meningitis, whatever this cause of meningitis, either TB, viral meningitis, or whatever. Don't forget always sarcoidosis, who is the brother or the sister of TB, and other syndromatic like neurofibromatosis, and sure, the malignancy, and as we mentioned, lymphoma, metastasis, you should include in any differential. This is something we can exclude it or neglect it, okay? And here, like some photo of angiography. So what it could be, I can describe, or someone volunteer who can describe that there is something going here, and this look like abnormal blush, right? And if you look here, you will find that many vessels are attenuated. So what it could be after you saw the MRI images, it can come to you this like a long case, and the idea that you will have good history probably, and in the history, if you have clinical data, exactly, Moyamoya of puff of smoke. This is what is characteristic to be puff of smoke. If you see this in the angiography, and who is specialized in angiography, he will find that is very famous. And in this case, you will think about Moyamoya. Moyamoya, one of the important topics, is not, to be honest, is not regular in the exams, but can be tricky case, okay? So take care and be careful about it, especially if he give you this appearance or this pattern, that the internal carotid, you always see like 3 dots. 1 dot here is the basilar, and 2 dots here, the carotid. If you don't see the triangle of 3 dots or circles, circle here and circle here and circle here of the 2 carotid and 1 basilar, so there is something wrong. So try to find the collaterals, and this is the key. If you find the collaterals, so you are talking about what is called Moyamoya disease. And the key in your, for example, in the MCQ, that you will find in the exam that there is something pointing that this patient is young, okay? So stroke in young, start to think about something in called Moyamoya and other types. Don't forget that it causes also some ischemia, atrophy, dilated ventricles, and you have many textbook, okay. Any volunteer want to share with us in this case? Okay, so what you see here is like an X-ray. It have something abnormal, maybe is going here, right? Exactly, Dr. Marwa. Again, I think Dr. Marwa, yes, exactly, yes. So it seems to be like ankylosing. Why you think, Dr. Marwa, ankylosing? Because I can see clearly that the facet joint articulation like phased and is not clear, not clear. You cannot see the facet joint in this case, so it will be the key. And also if you follow the distribution of anterior longitudinal, posterior longitudinal ligament, also the disc calcification are very characteristic in ankylosing. If you see disc calcification, you should think about ankylosing. They like it much in the exam. So please don't forget ankylosing. Ankylosing is very, and one of the tricky things is that they come to you in the MRI without X-ray, without CT. So this is more tricky. Ankylosing, they like it. Disc calcification, one of the key. Anyone sure that he know about ankylosing? Don't Forget about pseudoarthrosis, for example, one of the complications that can happen in the ankylosing. So, sorry, I'll just close this. Yeah. Ankylosing can show you, and the differential of ankylosing always, you see it even in the text, the dish. The dish, you see it like the calcification or ossification of the anterior longitudinal ligament, diffuse idiopathic skeletal hyperostosis, okay? Ossification of the posterior longitudinal ligament. They like it in the exams, but not like, not frequent like ankylosing. Ankylosing is more famous. It happened in the thoracic spine, although the cervical spine also included. OBBLL, posterior longitudinal ligament, also ossification is one of the differential. Okay, so let's. This also one of the important if you think about what is called Charcot or neurogenic arthropathy. When you see something very ugly, sure that your first thinking will be about Charcot or neurogenic arthropathy. And everyone he know about the 5 or 6 or 7 Ds that always in the textbook: destruction and dislocation and disorganization and density and debris. I know that many people saw it in the ankle. You always see the radiograph in the ankle, but it's important to know that you can have this in the spine. Like this case is not common, but you can see it or saw it. So whatever you have increased density, disorganization, dislocation, destruction with debris, you are talking about something linked to Charcot. Always ask about diabetes. So this is very important in the exam to not forget it. We will view it in the musculoskeletal when we come to it again. In the MRI, it looks like this, very ugly in the MRI. So think about diabetes and check it quickly, carefully, sorry. Some of the differential, very important differential when you go to the neck again, the differential between suburative node and peritonsillar abscess and retropharyngeal abscess or collection. And like this, maybe it can come to you in the exam for EDIR as a short question, and the differential diagnosis. List the differential diagnosis. So when you see collection and it is posterior to the pharynx, think about retropharyngeal abscess. When you see something linked to the oropharynx and is to the left or to the right or the lateral to or medial to the oropharyngeal pillar, so you are thinking about peritonsillar abscess. And in the nasopharyngeal site of lymph node metastasis, think about suburative node of Rovay, which is characteristic. Okay. Let's stop here. We have about I think we are about to finish the first session, but okay. Let's continue, and after this we can make like a shift. Okay. So now in this type, any volunteer can tell us what it could be, or what is the differential in this case? Yeah, you can think about extruded case, but before you go through the differential, check the clinical history, because if this patient underwent any type of operation or not. So this is a very important question, even in the practice. When someone come to you with this appearance, you should ask him if there is any operations or not. If there is any operation, it will be a bit different, because you cannot see here the posterior compartment. So maybe this patient underwent like spinal laminectomy or something like operation that it removed this, and this patient can be complicated. So whatever, one of the differential, sure that it can be like failed or recurrent herniation disc, and it can be also fibrosis or enhancing fibrosis. So you should be careful that you have differential if this patient have operation that include recurrent herniation, if you consider this one as a recurrent herniation, or recurrent fibrosis, fibrosis. After operation, he developed fibrosis. So be careful, don't rush to say that is herniation, because for many of us, يعني it's very easy to say that is herniation, right? Because you saw it many times in your life. But be careful to be يعني not operation, and this patient, for example, developed like fibrosis, like in this case, or for example, arachnoiditis, like this case. So be careful that this patient, this is myelography, CT myelography. I don't know if there is anyone is doing myelography still now, or, but whatever. When you see this, ask please about operation, especially if you have defective lamina. Here you don't see any lamina. So this patient, you have already something يعني tell you in the image that he have operation. So be careful in this case to not rush and say just herniation or something like disc extrusion. No, okay. We can يعني about 3 minutes. Okay, we have still 3 minutes before we shift to the next session, which will be real cases. So we need like some volunteers, real volunteers this time, not just chatting. But okay, so what about this? Something in the nasal fossa, and in this nasal fossa, you can see that it's obliterating the maxillary antrum يعني pathway, and there is also extension to the ethmoidal, and you see this soft tissue. First thing that you think about the type of patient. This type of patient is very, very important in the exam, that if you see something in the sinus, don't forget to ask, is it a boy? It is a young. So it can be something and enhancing, hypervascular, exactly. So as Dr. Min say, it will be angiofibroma. So don't forget it, because always we rush to nasal bulbosis or whatever. So don't rush to nasal bulbosis, rush before to ask, is it a boy, is it male? So this is a hypervascular lesion centered in pterygopalatine fossa. So we are going to, and the next step, he will ask you about next step, do angiography, and we should make some embolization to regress the size of the tumor. Exactly, adolescent boy, Dr. Naufal, exactly. So juvenile angiofibroma, one of the important, and they like it in the exam, so don't forget it, please, because in every exam, maybe you will have something similar. One of the, يعني, sometimes you can see something incidental like this when you find coloboma, which is like a conal extension of the eye sclera. So don't forget something like this. And they have like it because it's linked to something called charge syndrome. Coloboma, and I think it's have heart and many things, heart and ear, and as I remember. Okay. We are about 1 minute to finish the first session, with next session soon. Okay, so what about this spine? Anyone have any suggestion? I think it will be a bit easy for us. Yeah, I see some volunteers. So I see someone is trying to draw something very critical. I don't know. We are we are see. Okay, whatever. So what it could be, before I shift to the answer, يعني this very good thinking that you see this facet dislocation, or at least there is a fracture also here. So fracture and jambed facet is very, very good thinking. Yes. So let's go back and see how it can look. Yeah. So yeah. So when you see this, as we mentioned before, when you see one fracture, think about other fracture. And as يعني very good from Dr. Min and Dr. Marwa and everyone who mentioned that it could be locked facet or shifted facet or bear-shaped facet. And they have differentiation between facet dislocation and bear-shaped facet. But at least you mentioned that يعني this is like dislocation of facet or unilateral dislocation. Search for other fractures. This is the key. So now we'll stop and we'll shift again to another type of cases, and let's have